Yeah, I was seeing that.
Okay, all right, so we are live. So welcome everybody, and thank you for joining us for today's session on frequently asked questions on bispecific antibodies therapy in multiple myeloma. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I am joined by Dr. Jesus Berdeja from Tennessee Oncology in Nashville, Tennessee, and Dr. Melissa Alsina from Moffitt Cancer Center in Tampa, Florida. Patients and caregivers have a lot of questions about bispecific antibody therapies and their expanding role in the various stages of multiple myeloma management. So let's take a stab at answering some of them that we received in our recent webinar on bispecific antibodies, but unfortunately we're unable to answer due to time constraints. Okay, so I'd like to begin our discussion by first reviewing what bispecific antibody therapy is. Dr. Berdeja, can you broadly explain how bispecific antibody therapy works and what treatments have been approved for multiple myeloma and the stage of treatment that they're being used for?
Sure. We have 2 hours, right? For me to answer the question.
No.
So hello, everybody, again. No, this is obviously a very good question. So bispecific antibodies they're monoclonal antibodies that have 2 targets. So unlike the antibodies you're used to, like Darzalex or isatuximab, those are monoclonal antibodies with just 1 target. Usually the target is myeloma cell. Then the antibody then flags the immune system, and the immune system comes and kills the myeloma. With the bispecifics, on the other hand, you have 2 targets. So 1 target binds the myeloma cell, and the other target binds the T cells. And by doing so, it activates the T cells, and it's almost like lassoing the T cells to come and kill the myeloma cell. So you're basically almost kind of forcing or redirecting the T cells to the myeloma cells. And so those therapies are actually quite good. And 3 are currently FDA approved in the United States, 2 against BCMA, and 1 against GPRC5D. The BCMA, all of them had the same indication, which is after 4 prior lines of therapy and haven't had a prior proteasome inhibitor, kind of like a Velcade type drug, a prior IMiD, like a Revlimid type drug, and a prior anti-CD38 antibody like Darzalex. So that's when these would be used. And so teclistamab, elranatamab are the BCMA bispecific antibodies, and talquetamab is the GPRC5D bispecific.
Great. So we have Tecvayli, Talvey, and Elrexfio. So these are the biggies right now. And I think we're on the verge of probably having a couple more approved in the probably fairly near future. We'll talk a little bit more about that later. But Dr. Alsina, can you give an overview of how bispecific antibody therapies are administered and what a patient can expect when they're starting on this type of therapy? How often is it administered and how long they should expect to be on this therapy?
Sure. Good morning, everyone, and thank you for having me. So so all these 3 bispecific antibodies that have been approved are given as a sub-Q injection, so an injection under the skin. And the frequency varies depending on which one it is. But what is common to all 3 of them is that when patients are first exposed, they are at a higher risk of having like a reaction. We call that cytokine release syndrome, and it's like your immune system is very active, similar to when you have an infection, so patients can get a fever. And because of that, it's recommended that the initial doses are given inpatient, like a low dose, and then you wait. Usually, most commonly, we have to wait like 48 hours between doses, and then we give another dose, and then the 3rd dose. For teclistamab, we do 4 doses inpatient. However, these risks are very, very, they're very common, but they're not severe. So they're very manageable. So in many centers, we're moving to do this outpatient. So I think in the future, I would see these things are being administered outpatient, through the whole, particularly, obviously, if the patients are not having toxicity. And so again, depending on which bispecific antibody, you have to get 3 or 4 doses inpatient, and think about it like 48 hours apart in general. And then after that, you go and you get them in the clinic, and the BCMA targeting antibodies, elranatamab and teclistamab, they're given weekly, and then talquetamab is given every other week after that. And usually patients stay on this treatment until disease progression. However, we can change the frequency in those patients that are responding well, and that helps actually with the toxicity.
Great, perfect. So Dr. Berdeja, regarding the BCMA targeted bispecific antibody therapies, does every patient express BCMA on their myeloma cells, or are there ways to enhance its expression that might enhance the activity of these bispecific antibodies?
So the short answer is yes. So BCMA is a very important pathway for the survival and development of plasma cells. So technically, all plasma cells should express it. There are variances. So some patients may express it less than others. But luckily, the immune system is actually so potent that what we think is low expression is usually sufficient expression. So we don't usually test for BCMA expression. The second half of your question is, can we augment BCMA expression? The answer is yes. There are these drugs called gamma secretase inhibitors, which can lead to an increased expression on the surface of the cells. But it's unclear if we need them, and also at least the early studies being done with them show that these drugs have toxicities of their own. And so it's unclear how well of a partner they might be. But at least at this point, the answer is no, that's not necessary. We actually don't even test. The only other time where this might become a problem, and I think we'll talk about it later, is if you've had a prior BCMA therapy, there is a very small risk that you might lose expression to BCMA, and that is when this will become more relevant. But not if you've never had a drug directly against it.
Right. Okay, that makes sense. So, Dr. Alsina, are there patient populations for whom bispecific antibody therapies work better or worse? For example, are bispecific antibodies appropriate for like the older patient, and how well do they work in patients who have high risk multiple myeloma?
Yeah, so, always, high-risk myeloma and patients that have disease outside of the bone marrow, like we call that extramedullary disease, and patients that have, and perhaps patients that are over 75, or patients that have, very high tumor burden or rapidly progressing myeloma, these antibodies do not work as well. We see lower response rates. However, if the patient's response, actually the duration of response is about the same, right, that in other patients. So I would say while these types of myeloma, are challenging to treat with any drug, with any treatment, I would suggest that we could, that we still should try in these patient populations. The median time to response is about a month, so we would know fairly quickly if they're working or not. And then we can switch gears if they're not.
Right.
The other thing that I found, and I because this is just my experience, but I would definitely like Jesus to comment on this, that in patients that have rapidly progressing myeloma, like their myeloma is taking off, it's like the myeloma is moving faster than the antibody can work. It's helpful to try to give a different treatment, like for example, chemotherapy, to sort of control the disease before you can actually start the bispecific antibody. But this is not published data. This is just, what I've seen in my experience.
More like real world data.
Which is better than published data.
Maybe. Do you have that experience, or?
Well, I agree. I think, the patients who are rapidly progressing are challenging with all type treatment modalities, and I would argue that because of the intricacies of CAR T therapy, sometimes the bispecifics are easier. But you are right that those patients that are progressing quickly, sometimes they don't get that initial response, and then we have to move on, and maybe we didn't really give it a fair chance. But I think that's why it's nice now that these are approved. We don't have to kind of be as strict as the clinical trials. So I think in general, I think the patient who has controlled disease tends to do better. And so I think if we have some kind of bridging therapy, even though we talk about bridging therapy for CAR T, more so, I think a bridging therapy for bispecifics is not necessarily an unreasonable thing to do because of what you just mentioned.
Yeah. So, I think that it's interesting that we've seen a lot of real world data presented recently at some of the meetings, right? And I find that fascinating, right? So what they're really looking for is whether or not the real world use of the drug mirrors what happens in the clinical trials, where the patient population that is given the drug in the trial is much more prescribed. It's a very small percentage of patients actually can enroll in trials based on the inclusion and exclusion criteria. But I don't know, from what I've seen recently, it looks like real world data is actually mirroring pretty well what happens in the clinical trials, which is actually a good thing, I think. So
yeah, it's even one could argue that it's a little bit better, right? Because the population that we treat in the real world is much worse than the population that we treat in the trials. So it's reassuring to see that even in this patient population, which is the patients that we see, right, that these treatments still work in a very similar way than the studies show.
No, so it's good. It actually gives you confidence that you're actually seeing something that's going to be useful to the patients in the real world, not just patients who are on a clinical trial. So that's a good thing. So we've talked a little bit already about treatment sequencing. So in our previous bispecific antibody webinar that we had a few weeks ago, several patients had questions regarding sequencing of bispecific antibodies. And I know this is a very important question. Sequencing is very important when you start thinking about all of these anti-BCMA therapies, especially. So Dr. Berdeja, can you speak to some of the data regarding when it's best to use bispecifics, particularly the timing relative to other novel treatments like CAR T-cell therapy that may also target the same antigen on the surface of the cells, the BCMA?
Yeah, no. So this is, I think, a very hot button topic. Every single conference we go to now has this question and sort of the take on where we are, because the truth is we have very little data to help us. Most of the just a reminder that basically the majority of the BCMA trials with bispecifics and CAR Ts excluded patients who had prior BCMA therapies, although there are some that allowed a small group in a separate cohort. When you're switching the target, though, then that's a little bit different. So we do have good data with talquetamab, which is against GPRC5D, and that allowed patients with prior BCMA therapy. And about actually half the patients on that initial trial that got the drug approved actually had prior BCMA, and it seems to work quite well. So a lot of the data that we have is from these small cohorts, and also from real world data that was brought up earlier in terms of, obviously in the real world, we kind of go with what we have, right? So we can't be as specific as say, you had this before, you can't have this. Basically what it boils down to, in my opinion, and I'll be curious again to see what Melissa thinks here, but if you're sticking to the same target, let's say BCMA, because that's what we have different classes of drugs towards it, there definitely is a drop-off of the effectiveness of a second BCMA-directed therapy. And I would argue that it's even more so if you've had a bispecific antibody and then you move on to something else like a CAR T versus the opposite. So when in doubt, usually I say you give your CAR T first and then your bispecific. But really what boils down to is the mechanism of resistance. And so if, we are finding, the question becomes, if you're giving a bispecific and it stops working, is it because the T cells are exhausted, they don't work anymore, you go and collect those T cells and now the CAR T is not going to work because those are exhausted T cells, versus the bispecific, as we're finding out, can induce these mutations on the binding site of BCMA.
Yeah, that was some interesting data that they were showing recently. So,
right. So if that's the case, technically going with another BCMA may not work, but there's no reason why you couldn't go with a different target like GPRC5D. So again, as we're learning more, I think it will help us. But right now, I think in general, we all just kind of work with what we have. But no, there definitely is good data, especially the bispecifics, that after a CAR T against BCMA, for example, you still have very good responses.
Okay, so all right, so I guess we've already addressed this next question, talking about BCMA targeted bispecifics after treatment with another BCMA targeted bispecific. But I have seen some interesting work where patients are given both the GPRC5D targeted bispecific and the BCMA targeted bispecific at the same time. And that's also some really interesting data. Dr. Alsina, can you address that data?
Yeah, so that's obviously in clinical trials early on in the course of the disease. And yeah, you're trying to target two different, pathways to different proteins. So it's a very interesting approach. We're not there yet, but I think that would be in the future. And the other interesting thing would be not only doing at the same time, but sequencing them, right? Giving a few months of one and then a few months of the other. And so we're definitely looking forward to seeing those results. I think for the I agree with Jesus in terms of even though we need more data, if you have the option of getting a bispecific versus a CAR T, I would definitely do CAR T first, because there is data in the real world and also in clinical trials. So they have studied specifically CAR T after BCMA targeted therapy, and definitely decreases the response and how long the CAR T lasts. So until we get more information, that's the way we should go. But there also, probably the timing is also important, right? How long ago you received the BCMA targeted therapy. So there was some data in the real world that was presented at the hematology meeting in December that showed that if you had received your BCMA targeted therapy more than 6 months prior receiving the bispecific, specifically in this case was teclistamab, that the response rate was sustained, right? So that's important. So we need to learn a little bit more about that. So I would say it doesn't mean that you cannot receive these drugs sequentially, like receive elranatamab and then teclistamab, but I think probably the timing, the time that you wait between one drug and the other is important factor.
Yeah, that makes sense. Okay, so let's talk a little bit now about the toxicity and side effects of bispecific antibodies. So we have seen some reports of unique toxicities with bispecific antibodies. So Dr. Alsina, how do these treatment toxicities seen with the bispecifics compare with those seen with like CAR T cell therapy?
Yeah, so this is all, both CAR T and bispecifics are immunotherapy, right? Drugs that will use your immune system to kill the myeloma cells. So the typical side effects that we get with this is, you're like making your immune system super active, killing the myeloma, and that causes this release of a lot of proteins. We call that cytokine release syndrome. And that most commonly give the patients a fever, but it could also be more than that, like hypotension, low oxygen, shortness of breath, and it could be quite severe, right? And we learn a lot about this with CAR Ts over the past, I don't know, how many years now, probably, I don't know. I don't
7
know,
years.
7, right? So with the CAR T, these things seems to be more significant, even though they're very manageable. And but it requires more aggressive therapy in many patients. The other thing is neurotoxicity, and which means you can have affect your central nervous system, and patients can get anything from headaches to mental status changes. And this also can be seen with CAR T and bispecifics, but in CAR T it's also more significant. With bispecifics, it usually tends to be only when you're getting those initial doses, like in the first month of therapy. And even though it's common, like we can see usually probably in 70% of the patients, the cytokine release syndrome is mild, so it's very manageable. So rarely we will see a patient with a severe reaction. And the same thing stands with the neurotoxicity, right? We essentially do not see, just very little, neurotoxicity with the bispecifics. So yeah, similar, but much less severity with the bispecifics. I think with the bispecifics, to me, the more concerning thing is the infections. These cells are suppressing these drugs are suppressing your immune system. With CAR T, the same thing happens, but CAR T, you do it once and then you recover, right? Especially in patients that get in complete remission, their immune system recovers and they get better. But with the bispecifics, you keep doing it month after month, month after month. So yes, this is an issue. The rate of really severe infections, meaning you require intervention, hospital, going to the hospital to be treated, is over 50%. So with the BCMA targeting bispecifics, with elranatamab and teclistamab, with the other one, talquetamab, the side effects are actually different. I don't know if you're going to address that later, but essentially, to me, the main thing is infections, and we really have to be very aggressive trying to prevent these infections in these patients. And the other thing that we can do is also, when the patient achieves a response, backing off a little bit. In some cases, we can reduce the dose, or we can lengthen the time between doses, like instead of going weekly, every other week, in some cases, even once a month. And that definitely decreases this risk of infections. And I don't know, are you going to address later how we manage this? Should I stop now?
Let's see. Actually, no, you can talk about that now if you'd like to. Go ahead.
Oh, okay. Well, maybe Jesus, this is, there's not a lot of data really published about this, but each center follows their own protocol. In our center, we do prophylaxis for herpes zoster in every patient, acyclovir. We check the CD4 count, which is some part of your immune system that, these are the cells that are more active dealing with infections. And if that number is low, we give the patients a medication to prevent for opportunistic pneumonias. This will require taking an additional drug and sometimes an infusion in the vein. And we also, if the patients have low immunoglobulins and are getting, frequent infections, we also give a IVIG to these patients with an infusion of like an immune system booster, but that patients have to take once a month. And then be very aggressive with, anytime the patient develops a fever or any sign of infection, be very aggressive with treating this.
Okay. Right. So, so some patients also during our webinar asked about the toxic hematologic effects seen with bispecifics and how those are managed. So, Dr. Berdeja, can you address that?
Sure. I think it's important to note that all of these therapies lead to both CAR Ts and bispecific lead to significant drops in your blood cell counts. I think the idea is that it tends to happen early, and it likely has to do with sort of the immune system being activated, going into the bone marrow, killing myeloma cells, causing some stunning of the bone marrow that leads to sort of these very quick drops in the blood counts. But in my opinion, and as we're seeing with the bispecifics, is even though you continue to give the bispecific, the blood counts usually recover and they do better, suggesting that it's not the bispecific again, and it's more sort of this sort of immune-mediated sort of initial effect as you're killing the myeloma cells. Having said that, this can take a while, so it is very important to make sure that your blood counts are checked very frequently, and some people will need transfusions, some people will need growth factors to help them sort of kind of bridge this period of time. And if a patient does become neutropenic, meaning you lose your neutrophil counts, that adds an extra level of immune deficiency than what Dr. Alsina just mentioned in terms of the cellular immune deficiencies and humoral, meaning the antibodies and the T cells. But now your neutrophils are also down, which usually means we then have to introduce antibiotics and maybe some antifungals during that period of time. So again, really, it's all sort of tied together in terms of the toxicities, the blood cell counts as well as the infections.
Sure. Okay. So we've been talking about infection. We've talked a little bit about how to prevent the infection. Dr. Alsina, several patients mentioned in our webinar that how important it is to repeat their vaccinations. So can you speak to that?
Mm-hmm. So yeah, definitely. I mean, after CAR T, we do start vaccinations all over again, like similar to after you had a transplant, you do all the baby shots, and usually patients are vaccinated for 2 years at different intervals. After bispecific, we don't necessarily repeat all the baby vaccinations, but we make sure patients are up to date, right, in their vaccines. Definitely super important to get the COVID boosters, the pneumonia shots, and also the flu shot. And now, most recently, right, we've been doing also the RSV shot. So yeah, that's even more important in these patients, that are getting these treatments that compromise their immune system.
Yeah.
By the way, the other important thing, the infections that we see, after bispecifics are different, right, than the infections that we see typically in myeloma. These are more opportunistic infections, viral infections that we normally are not used to see. So it's a different, part of your immune system, the one that is more affected. So we have to pay more attention to that. Like, for example, cytomegalovirus, that is a virus that most of us have, are colonized by that virus. But if your immune system is normal, you would not get an infection with that. And so that is something also that we have to pay attention to, right? Thinking a little bit out of the box when a patient comes with a fever and a clinical picture suggestive of an infection.
Can I just add one thing to the vaccines? So I completely agree with what Dr. Alsina just said, but the only thing I would also mention is that the response to vaccines is not going to be as good for someone who is on these treatments. So if at all possible, if there's going to be a delay or you're going to wait, you want to do, and you haven't had your vaccines recently, you want to do those vaccines before you start the treatment. That was the only thing I was going to add.
Yeah, well, that makes sense, right. So I guess there were some patients who wrote in with some pretty specific questions here. So they were having issues with some of the infection prophylaxis measures, right? So there was one patient who said they couldn't tolerate the IVIG. There was another patient who couldn't tolerate dapsone and is on pentamidine and wondering if they can discontinue that. So what are some of the options for patients who have issues for some of these standard prophylactic measures? And is reducing the frequency of administration of the bispecific an option for that, Dr. Berdeja?
Yeah, so I mean, that's obviously a difficult situation. So Dr. Alsina mentioned all the reasons why patients on these treatments are so heavily immunocompromised and at risk for infections of all different types, but especially these sort of odd, atypical infections, right? That we are used to seeing. We used to see them in the old AIDS days, those kind of infections. We're talking about that level of immunodeficiency. But actually, I would argue even more so, because that was all T-cell deficiency, which we have here. But remember, the target is actually your plasma cells, which are the cells that make your antibodies. So you have not only T-cell deficiencies, but you also would have antibody deficiency, or we call humoral deficiencies. And so it brings in an increased risk So yes, I agree that not everybody will be able to tolerate all of the prophylaxis, but just like this patient is doing, the important thing is that we find something that can be tolerable to maintain that prophylaxis, because the alternative is essentially a life-threatening infection. And so yes, so I think Dr. Alsina mentioned one of these things that we can do is, for example, check a CD34 count, which is the cells that, when they're suppressed, are the ones that increase that risk for PJP, which is what that Bactrim, the dapsone, the pentamidine are for. And so if that patient's CD4 count has recovered, then that person could potentially come off the prophylaxis and be monitored. But if not, then yes, then we need to kind of figure this out. The alternative is also, yes, if the patient's in complete remission, then there's a potential to increase the interval, potentially even hold therapy. So there, that's not the actual indication recommendation, but we all have data, and there's actually some data with some of the bispecifics where there's actually a limited duration of therapy, and then we stop. And we know that responses can be maintained off therapy, so that potentially is another option as well. You have to weigh the pros and cons with your doctor and decide what makes the most sense.
There was an FDA approval. Was it last week for teclistamab for increasing the interval between doses, right, to like 3 weeks or something like that, right? Is that right?
Well, it's actually after 6 months of therapy for patients in complete remission. Then because teclistamab is given weekly, then you can go to every other week, which is interesting because actually elranatamab actually has it built into their indication already that after a certain amount of therapy that they go from weekly to every other week. But again, that all goes back to sort of kind of how the studies were done. But the good news is we're all finding out that perhaps we don't need to give it as frequently as we've been doing. And again, I know we'll talk about it, but there's one particular antibody that only goes for a year and then it stops.
Yeah. That was that Cevostamab data. That was really, really interesting. So we had Dr. Trudell on a webinar not too long ago, and she was talking about that as fascinating data, right? A year of treatment, and then patients have gone off, and everybody who was in a complete remission at the time that they went off the therapy is still doing well. So that bodes well, I think, for this class of drugs. So, so Dr. Alsina, speaking about side effects from some of these drugs, patients were wondering about changes to their sense of taste after being on a bispecific and whether or not that will ever resolve itself. Can you speak to that? And I'm assuming these are probably patients who have been on Talvey or talquetamab, right? Because that's really where that effect comes from.
Right. That is a very common and difficult question that we get recently because we don't have, unfortunately, a really good answer or solution for that. But yes, that is from talquetamab, which is a bispecific antibody that targets GPRC5D. This protein is expressed in follicles, in the skin, in the mucous membranes. So patients would get side effects associated to that, they get the nails get really bad, the skin gets really dry, and patients frequently can get a rash that could be very bothersome. And then they get this loss of taste, and then as a result of that, they get weight loss. Yeah. So this is a different set of side effects, and unfortunately, we don't have any good way of managing this. What I do in my practice, I have all the patients take biotin, and also do biotin washes, and then have them use a lotion, try to keep the skin super hydrated when they start therapy. It's interesting though that even though these side effects are difficult to manage in the studies, and in my experience also, rarely we adjust treatment based on this. It's like if the treatment is working, the patients manage it, right, and put up with it. I wish we had a better solution for this, but in the study with talquetamab, they also look at changing the frequency or decreasing the dose, right, from 0.8 to 0.4, and then see what happens with these side effects. And that intervention helped with the skin. The skin didn't continue to get worse when you do that. It really did not do a huge difference in terms of the weight loss or the taste. But I mean, I guess those are things that we could try, and some of the physical measures. But it's challenging. It's a very challenging side effect to manage. I don't know what is your experience, Jesus?
Yeah, no, I completely agree with that. But I guess the short answer to that patient's question is it will go away when you're off the drug. So that's the good news, is that it actually is because of the drug, and it will go away. But I think also just talking to patients and saying, the fact that you're getting these side effects actually shows us that the drug is working.
Yeah, right.
And often that really helps psychologically in terms of okay, well, this is sort of part of it. But I agree with Melissa that at least in my experience, very similar to kind of with the low blood counts, is sort of the flares are worse at the beginning, and then for whether it's because the patient starts doing different things or where truly the toxicity is diminishing some, it doesn't seem as severe as you go along. The only other thing I would add to is that patients can get very dry mouths, and so I think learning that taking lots of liquids with their food and avoiding, having just a piece of bread, a dry bread by itself. I think those modifications really help with the nutrition. But ultimately it's stopping the drug, unfortunately.
Yeah. Well. Okay, so let's talk a little bit about what's next for bispecifics. So we currently have 3 approved, and there certainly are probably at least 3 additional ones in the pipeline edging up toward approval. So let's see. Yeah, so several patients asked about use of bispecifics in earlier lines of therapy. So Dr. Berdeja, how close are we to that being an option? And I know that we're really thinking about that as far as CAR T therapy as well. And the FDA is addressing that actually next month. right, in their public hearings, et cetera, et cetera. So that'll be really an interesting day on March 15th when the FDA talks both about Carvykti and Abecma in earlier lines of therapy on the same day. So.
Yes. So, the short answer is we're not as close with the bispecifics as with CAR T, but there are ongoing trials currently looking at CAR T or bispecific antibodies in earlier lines of therapy by themselves or in combination with some of the other drugs like people are used to, like bortezomib and carfilzomib and pomalidomide, etc. So those trials are ongoing, and we actually have some pretty interesting data that's starting to come out and being presented with the early patients that are enrolling, which actually looks quite good. So, the response rates that we're seeing are actually much higher than the response rates we're seeing in the relapsed refractory population that got these drugs approved to begin with. And oftentimes in populations where the companion drug had already been given, and often the patient was already refractory to. So, for example, patients who were refractory to Darzalex, for example, and then got Darzalex with talquetamab, actually had very, very high response rates, more than we would expect with either the drug alone. So that's actually encouraging from that standpoint. I think and then actually there's even now some protocols looking at potentially even frontline therapy. So that's when newly diagnosed patients, again in combination, and even some by themselves actually, because we're seeing these profound responses, I think you can sort of entertain the possibilities. Do we even need to combine? The caveat here is that anytime you start to move to a different indication, you want to make sure that they're safe, right? We've been talking about these infections, right? If we get a little too careless, right? We give bispecifics for the newly diagnosed patient and they have a bad infection and don't survive those infections. That's not a good outcome. Yeah. So we need to be really careful with these drugs and really learn how to use them. The other thing is, it's, again, these are so powerful, at least in my mind. I'm still unclear as to the actual benefit of combination and whether we're just adding toxicity as opposed to kind of doing these separately. So lots still to learn. So I don't think we're ready for prime time yet for moving these into earlier lines of therapy. But what I'm hoping will happen, which Mary was just commenting on the FDA meeting that was had with the IMS last week, is that we move away from this line of therapy. That it's very clear that patients who've had the three big classes of drugs, the proteasome inhibitors, the immune modulating therapies, and the anti-CD38 antibodies, do very poorly with standard of care therapies, and these bispecifics and CAR Ts work so much better. And so we're really hoping that as this early data starts coming in, that maybe we'll move away from the requirement that you have so many lines, as opposed to just having been exposed to the classes of drugs. Right. And I think that's sort of where we're headed. So hopefully more to come.
Yeah, that was actually a really interesting outcome from that conference, right? So moving away from lines of therapy and really just looking at what the patient has been exposed to and what they're potentially refractory to, instead of how many lines of therapy they've had, which I think makes good sense. So Dr. Alsina, in this webinar that we had a few weeks ago, there were a couple of patients who were scheduled for autologous stem cell transplant, and they're wondering if they should have bispecific antibody therapy instead of a transplant. Now, that I know, I mean, are there any trials that are actually addressing that? Because I know that there are trials that are addressing patients having a CAR T instead of a transplant, but I have not heard anything about patients having a bispecific instead of a transplant. That seems to be a little way too forward at this point.
Yeah, the short answer for that is no. I mean, I think, induction therapy nowadays with myeloma with 4 drugs, so, including a CD38 antibody, followed by transplant, followed by maintenance therapy, and following this, sort of what we call MRD adapted approach. That means I'm going to push until I get to the best possible response, hopefully a deep response, give the patients a long time without disease, right? So until proven otherwise, we should not change that approach, because it is a really good approach. And, I'm super impressed, Jesus, by the data, right, presented at ASH on the Perseus study, the ISCIA study. studies that look at 4-drug combination followed by transplant, followed by maintenance, these studies do not have enough follow-up to tell me, okay, this is going to last 10 years or how long, but it looks so good, that even studies that are looking right now at comparing CAR T, like substituting transplant for a CAR T, they're going to take a long time to show that is better to transplant because it's so good, that initial approach. So no, I think we still have some treatments that are very effective, that are standard of care, especially for newly diagnosed patients.
Yep.
And we should not move away from that until we get data. But the data, again, is going to take a long, long time because the bar is very high and it's getting higher, right, as we speak. So now, in the relapse setting, that's a completely different story, right? And I think once you have a patient with relapse myeloma, in reality, it's a complete different challenge. And yes, I would agree that we should not wait until a patient has failed everything to introduce these treatment modalities that are so effective, right? I think it's going to work better when we use them early, and it's going to work better also when we use it as consolidation, meaning I'm doing my initial therapy, but my patient did not get to that deep response that I'm looking for, right? Being able to do consolidation with those drugs. And there are trials right now looking at that. Like I do, for example, let's say in a non-transplant patient, right? Patient that is not going to get a transplant, I do my best possible treatment, let's say daratumumab, lenalidomide, and dexamethasone, and I don't get where I need, then sequencing with a bispecific antibody, right? To see if I can get to that response that I need, a deep response that is associated with better survival and so on. So I hope that answered your question.
Yes, I think so.
I'll just add something really quick that I completely agree. This is not standard of care, so they're not. You don't equate them. Yes. Having said that, if you are interested in something, there are clinical trials looking at that, right? So, so if you find those clinical trials, you may be able to get a CAR T or bispecific plus or minus a transplant or without a transplant. But again, it would only be on a clinical trial. It would not be a standard of care. That would not be recommended.
Yeah, absolutely. Okay, so we've discussed the three biggies so far, right? Teclistamab, elranatamab, and talquetamab. So I know that there's newer ones that are in the pipeline. We talked a little bit about cevostamab, which seems like it's going to be probably pretty good, and it seems like it's pretty far along, so it probably will be approved fairly soon. And there's other ones too, like alnuctamab and some other ones, right? Have I missed any?
Yes, but I'm blanking on the name.
The Regeneron product too, right?
Okay.
Yes. So there's about 6 BCMA bispecifics, right?
Right.
So
Right.
So we have 2 approved, and for the truth is all that data looks really good.
Yeah.
And they all look quite similar. So it'll be interesting to see what happens, whether the FDA approves all of them or if they have to prove something different. That's the question.
Yeah.
But in terms of the efficacy data, it all looks very similar.
Sure.
I think what we're excited about with cevostamab is that it's a different target.
Exactly.
What we were talking about before, kind of having sort of that extra target that we can go after if and when a patient were to no longer have response to a current target. So cevostamab goes against FcRH5. So those are the 3 big targets in myeloma right now.
Right. Okay, so that'll be really interesting. Okay, so a couple of final thoughts. So Dr. Berdeja, how have bispecifics, both the BCMA targeted and the non-BCMA targeted, affected the outcomes of patients that you manage? I mean, have you been really impressed with how active they are and how much they've helped the patients so far?
I am. So, so I was lucky, and my patients were lucky enough to be able to participate on these or receive these drugs on clinical trials so we've been using them for years now, and they're very impressive. It's very similar to sort of kind of when CAR Ts came in and made that big splash in terms of the efficacy we're seeing. I think patients really like them, and I have to say, it's like we keep talking about which is the best patient for this or that, but ultimately it comes down to patient preference too. So I have patients who are addicted to CAR Ts and will not have anything but a CAR T. And luckily on clinical trials, you can do CAR Ts against different targets. And so patients have gone serially with CAR Ts. And then I have patients where we talk about the two options and they're petrified of the CAR T and they're like, I want to do the bispecific, I don't want to do the CAR T. And so just remember that, again, it's a conversation. And because both options are very good, I think it's hard to be very dogmatic about it. You know, if you want to maximize the available therapies, that's when we start talking about, you know, which one do you do first, etc.
Right.
But no, I especially with the BCMA bispecifics, I think it's very well tolerated. I think most people, once you get beyond that initial step up, you know, most people come in for an injection, leave, and that's it. The infections is the big concern here, and but obviously those are not side effects necessarily. Those are just, you know, risks that if managed properly, hopefully you stay away from. The GP talquetamab, again, I've had patients who are been on it for like 3 years and they would never stop it. I try to stop it and they won't. So even though they have some of these sort of what we call off tumor on target effects, you know, the side effects of the taste and the skin and the nails that we didn't even talk about, it's worked so well for them. They've never, you know, I had patients who have never been in a complete response and all of a sudden they're in a complete response now going for years. So yes, so we do see these dramatic potential responses with these therapies, and it's just a matter of learning how to use it best. Because ideally, the plus of CAR Ts versus bispecific, in my mind, is the idea that you're off therapy. CAR Ts give treatment and then you're off therapy, which is unusual for a patient, whereas the bispecifics follow the same modality with all of our therapies, that is continuous.
At least for now, anyway.
I have a question for Jesus. I'm curious. So, you know, based on this combination data, like with talquetamab, Dara, for example, upfront, those studies, do you ever have a patient, for example, that is progressing on talquetamab and you add Dara or you add Pomalyst? And if you've done it, do you see a response or?
Yeah, you shouldn't be asking me those kind of questions.
I'm sorry.
Those are not FDA approved combinations. But having said that, actually, I haven't done that necessarily that way, mostly because I think it's what you said before. It's if the bispecific's not working already and you add something like Pomalyst or talquetamab, the likelihood of kind of achieving enough of a new response is pretty low in my mind. But I think it's different in some, like you said at the beginning, where you're trying to really kind of get a hold of the disease, where I think the combination makes the most sense, and then you kind of can peel it off and just continue bispecific. I think it's different if, let's say, you have a patient who maybe have a partial response and not a complete response. I think at that point you could argue, well, what if we add something? Can we deepen the response? But once the patient is progressing, I don't think adding just POM or DARA is gonna, especially if they're already refractory, right, to it.
Okay, was just curious.
I'm glad that we're like providing a forum so you can have, you know, this professional interaction and discuss your treatment modalities of your patients.
Well, but your patients should know that this is what we do. This is what's great about the myeloma community. We know each other so well. We will pick up the phone, we'll talk, and we'll say, hey, I have a patient. What do you do? Have you ever done this? And I think it's important that we have those kind of conversations.
Yeah,
I totally agree.
Yeah, well, because, you know, I think in the past, you know, our challenge was, okay, what do we do when the patients have the first relapse? Now the challenge is, what do we do when the patients have their, 14th relapse, you know? So patients eventually progress after bispecific. So that's our new challenge, right? What do I do? What do we do? What's my next step, right? When my patients progress after that. Even though, of course, there's a lot of clinical trials, so that's always our go-to, right?
Okay, so that's a great segue to my final question, Dr. Alsina. So if you had a crystal ball and you could look in there and see what's going to be happening with your bispecific therapies in the next few years, what would you predict we would see with some of these bispecifics, you know, as time goes by?
Yeah, so I mean, I think I don't need a crystal ball because it has been our experience for, you know, over 30 years now of myeloma therapy, that every treatment, that works in the relapse setting, we move it up front and do it in earlier lines of therapy, and it works better, and it deepens our responses, and that's the reason we got where we are right now, right, with first-line therapy in myeloma. So I think that's what's going to happen. It's happening already in clinical trials, moving these drugs for earlier lines of therapy, even in the newly diagnosed, there's even studies ongoing in high-risk smoldering myeloma, right? I think in that setting, more than those drugs are going to work better, and also in combination with other classes of drugs, and hopefully will give the patients deeper responses and more time as a result of that.
Okay.
So there is, definitely very exciting times. I think it's incredible, right? How far we've come, and I think the hope it continues, right? It grows as time goes by. So
yeah, it's kind of amazing. I mean, Jesus was talking before about this FDA IMS meeting that was this past week. And there was a lot of talk about the fact that we've had 19 drug approvals in myeloma in the last 20 years, which is a phenomenal number, right? So, and I always, when people ask me about that, I always say that I think the reason that the progress has been so amazing is that this is such a challenging disease, and it really attracts, because of that challenge, the best medical minds, right? Go to myeloma because it's so challenging. And like you were saying, you guys all know each other. You all talk to each other. It's a great community. And this has really helped move the myeloma community forward, because you guys all work so hard and you're so smart, and these great drugs come out and all the patients get them. And it's just amazing to see how far these things have come in 20 years, right? So 20 years ago, it was just like, you had myeloma and you had maybe like 3 years to live or something. And that is no longer the case. So
yeah, well, it takes a village, right? We are a little part of this, right? But also the pharmaceutical companies, the foundations, and I think more than anything, the patients, right, that decide that they're going to participate in these clinical trials.
Yep.
And that's the only way the field will move forward. So
yeah, agree. Okay, so see, that didn't even take an hour, Jesus.
I was just going to say that, the only thing, I really love what Melissa said before about how amazing the data looks for newly diagnosed patients, especially the standard risk patients, right, with the current regimens, and how long it's going to take to sort of prove that something else would be better. It's a double-edged sword. So just a reminder to our patients that if you're newly diagnosed, you have excellent therapies. But don't get discouraged at the fact that you can't get a CAR T or you can't get a bispecific, because those trials are ongoing now, and it may prove 10 years from now that that is what we need to be doing.
Sure.
But again, we're sort of a victim of our own success, I guess, in that standpoint. But that's a good problem to have.
It is a good problem to have. A very good problem to have. Okay, so on behalf of the MMRF, I'd like to thank Dr. Berdeja and Dr. Alsina for joining me today. I'd like to thank everyone for taking the time out of their day to watch our presentation here. And finally, I'd like to thank our sponsors, AbbVie, Genentech, Janssen, Pfizer, and Regeneron for sponsoring this session. If you have any additional questions about what you heard today, please don't hesitate to call our Patient Navigation Center at the MMRF. Their number is 1-888-841-6673. Thank you, and have a great rest of your day.
Thank you.
Thank you.